Hey, this is Steve Kravanik. This is the 2021 third quarter update for the EMS action items. I'm here with Dr. Roach, and join us for some of the hot topic items that have come out of the meeting.
Hey everybody, it's Dr. Roach here. Look forward to the discussion.
So for the EMS performance snapshot for the third quarter 2021, looking at our on-scene times, trauma and stroke, the goal there is 10 minutes, so we have a little bit of opportunity to make some improvements there. As far as the 12-lead EKG, phenomenal, so we're at 6 minutes. So just consider these trauma patients and stroke patients. Again, these are alerts, and the idea of an alert is to get off scene, get them to the hospital as soon as possible. Moving on to ROSC. Our ROSC rate is 32%, which is great, but there's definitely opportunities, and I think that we could stay on scene, work the pit crew on scene. Again, I want to emphasize the pit crew CPR triangle is meant to make your jobs easier and improve outcomes for our patients in the community. So please make every effort to stay on scene and at least get the 6 minutes that we've talked about in the past when we go around to the stations, that first 6 minutes at least to finish all the objectives of the pit crew CPR. The rescue pod, our goal is 100%. We're at 93%. This is a device that definitely improves the neurologically intact survival by increasing blood flow to the brain. It's called an impedance threshold device, is what ITD stands for. Make sure that you document that not just in the chart, but the flow chart as well. So that will help us capture the data. So thank you for doing that. And then end-tidal CO2 is 95%, so we're only about 5% off our goal of 100%. So again, the end-tidal CO2 and the rescue pod, those are specific objectives of the pit crew CPR. SOGE 132 and SOGE 128. Everyone, this is just a reminder about shift report review and timely completion of the reports. We need these charts to be locked by the end of the shift.
There's been some questions recently whether or not it's its own protocol, or if it's a protocol only for trauma, or if can we use it in trauma or medical. And I know we had talked about in the past some of these terms like shock index, and it's some of the things that are not necessarily in the protocol, but I think they're really important to people to understand that, so we know when a whole blood opportunity is something that we can attain, and we can get early blood on board.
Absolutely, absolutely. So all hemorrhagic shock will benefit from whole blood. We had a case, Captain Meadows came on scene. The patient had a heart rate of 130 with a systolic blood pressure of 90. So if you take the heart rate divided by the systolic blood pressure, 130 over 90, it's going to give you about a 1.4 shock index. A shock index greater than 1 with an end-tidal less than 25 has a 5-minute impending
Cardiac arrest.
Cardiac arrest, right.
Yep.
So this poor woman with a hemorrhagic bleed, she's bleeding from an upper GI ulcer or esophageal varice, whatever the case is. And Captain Meadows came on scene. She's in shock. She was clammy, is what he said, abnormal vital signs. As I said, shock index was 1.4. He gave 1 unit of whole blood, which normalized the vital signs. This lady came in. I mean, that's huge.
It's life-saving.
That's life-saving.
It's life-saving. And I also want to take a minute to talk about, how that call transpired. So the officer on scene was heads up enough to go, hey, listen, I think this might be a whole blood opportunity. Let me get an EMS captain on the phone and see what he thinks. And they didn't delay their scene time by, waiting around on scene for Captain Meadows to get there. They actually rendezvoused with EMS 17 in a parking lot, and they were able to leave his truck there and continue. So they didn't delay them, and I just think that was outstanding, care from start to finish. And I just wanted to take a minute to recognize them. But the shock index, can you talk a minute more about how you calculated that shock index score?
Yeah. So it's very simple. If you take the heart rate and divide by the systolic blood pressure, so the normal number should be around 0.5, 0.7. As you start to get above 1. Now you're in the area. And if you look at our protocol, that's the hemorrhagic shock protocol, where we give whole blood. It talks about the shock index, and it gives you criteria based on age, and even in there we have end-tidal CO2. So a low end-tidal CO2, they're obviously hyperventilating, they're in shock, they're acidotic. So yeah, these are the things. And a shock index, as you see a shock index greater than 1, you need to really start thinking about whole blood. In both, not just trauma, hemorrhagic shock, but medical.
Right. I mean, you got to fix the volume loss some way, and that we're only going to do that with whole blood. We're not going to wash them out with saline. Something that also you touched on was the end tidal, That's something that we're not too big on in trauma, and I think that goes back to we're usually providing some kind of high flow oxygen with a non-rebreather mask or BVM ventilations, and we're not really thinking about that. Maybe with BVM we are, but having that end tidal on them early on in the game with a medical patient, maybe it's not indicated. They're not shortness of breath. They're not having a low O2 sat. But if you put that end tidal on them, you see that they're less than 25. It's a great indicator that they're confirming that they are bleeding out.
Yeah, absolutely. More
Things that we're always monitoring is the scene times for air rescue and how long we're staying on scene versus how long it took them to dispatch air rescue and get them early on that call. And it's something that we keep pounding the drum on and making sure. And overall, we're doing a great job. I think that sometimes there's some challenges in some of the rural areas, like at 106 and stuff like that, whether or not it's going to be taken by ground or by air. I would like to see them just, if they're in that decision-making process, to just go with the patient's best interest and take them by air. But that brings up another topic. That brings up the discussion about trauma transfer. So we have this, we get beat into our head about the trauma transport guidelines and protocol about red versus blue and how many blues and all this stuff. But that really doesn't come into play when we talk in the hospital setting for an inter-facility. Can you elaborate on that?
Absolutely. Yeah, so our fire rescue personnel are the masters of that blue-red criteria, knowing what the trauma criteria are, and so you have that down to a science. The difference is inter-facility trauma. In the protocols towards the end of our trauma in the protocol app, you can see the interfacility criteria. So that's different than a trauma. So just because someone's a trauma transfer doesn't necessarily mean they're a trauma alert. They could be. But if they meet, and you could read that page where you could see the specific indications where a hospital that's not a trauma center would have to send a patient to a trauma center. Now, by Broward County ordinance, they have to go by fire rescue. They cannot go by a private ambulance when it comes to trauma transfers. That has to happen. The next question is, does this person go by ground or by air? And that's a discussion that should be had between the physician that's transferring the patient and the fire rescue personnel on scene. Right. If you feel compelled to call air rescue and you have a good judgment on that, that's your judgment on that, then talk to the doctor, and that's something that you can decide to do. But many of the trauma transfer cases are just going because that's the higher level of care. They have trauma specialists that can manage the patient as an inpatient.
Not necessarily that they're going to die if they don't get on a table in 60 minutes.
Right.
That whole golden hour thing is what we're always thinking about. Like, oh well, if I'm in Weston and there's a trauma transport coming out of Cleveland Clinic, or something like that,
right,
then I need to get air rescue. And listen, honestly, I like I've talked to you before, I don't mind that they call air rescue and get the ball started. When they get there, though, they need to have enough understanding, though, that this is the sending doctor's overall decision on how they take care of that patient.
Yeah.
And they're not going to make the wrong one. And if they think it might be a wrong decision being made, have that communication with that sending physician to make sure that they're doing the right thing.
Absolutely. And in many cases, the patient's been in the emergency department for 3 or 4 hours, has had multiple sets of vital signs, had CAT scans of, sometimes even a pan scan where we've CAT scanned from top to bottom, and we know exactly what the injuries are, and they're specific injuries. We know, and they're stable. So in that case, there's really no reason to bring somebody by air rescue. Now, we also could have a situation where somebody could come in with an emergency, and we haven't had the chance to do diagnostics, the patient's unstable, and we would call for a trauma transfer that's going to require air rescue.
Right.
And whole blood, potentially.
Right. Whole blood, ventilator transport. Those critical care patients that are going, they may not feel comfortable with doing that, and that's something they can also discuss with that sending doctor. And remember, I always want them to feel comfortable reaching out to an EMS captain and getting a second opinion, or a battalion chief if there isn't an EMS captain that day. But just understanding the workflow. Dr. Roach and I have been reviewing several cardiac arrest cases over the last, I would say, almost a year period or so, would you say?
Yep. That
we're seeing a lot of refractory VFibs. And this is like an uncommon problem or a challenge that we haven't seen a lot in our career. One of the things that I have not seen is anyone using the opportunity for these refractory VFibs to do the dual sequential defibrillation. And I know we've talked about it in the past about how important it is to make sure that you get both monitors on scene, you place the pads anterior and posterior, but we're not seeing that.
We're not.
And I wanted to have Dr. Roach talk a minute about why that's so important to have that placement done early on in the game.
Yes, so I'm going to start off with my general discussion, which is my primary goal is to improve outcomes for the community and make your jobs easier. Part of making your jobs easier is to create efficiency within the system, which is why we created Pit Crew CPR, which is why we have these steps outlined pretty specifically. One of the steps in the Pit Crew CPR is to hook up the pads anterior and posterior on the first run. That way, when you get into using the auto pulse, you don't have to detach the auto pulse to hook up the pads anterior and posterior. So, and then now thinking about the evidence, anterior and posterior vector gives you your best chance to have a successful defibrillation or cardioversion, depending on what you're doing. So, it is primarily important to put the initial set of pads anterior and posterior.
And I know I've gotten feedback from people like, well, why don't they put the graphic on the pads as anterior lateral instead of or anterior posterior versus anterior lateral? And we've reached out to Zola, and that's a large amount of money that Zola's going to have to invest with the FDA to get that sticker changed. But they do recommend that the absolute best placement is to do anterior and posterior. So if you start out anterior and posterior, you get the auto pulse on, and they're in a refractory VFib. Guess what? Engine comes there with the second monitor. Hooked up those anterior and lateral pads, and then you can do the dual sequential defibrillation. We've been talking a lot about how to increase effectiveness in cardiac arrest, specifically how to avoid some pitfalls and how to improve overall performance from all different perspectives. Specifically, when we talk about PEA, we always talk about a lot of H's and T's and how to reverse these H's and T's. And I think what we're seeing is a lot of trend, Doc, with people giving Narcan just because they think, well, we're not sure if they were an opioid overdose or they were a confirmed heroin user and it caused a cardiac arrest. Their thought is that they give the Narcan, it's going to bring them out of the cardiac arrest. What's your feelings on that?
Yeah, so we were looking at the data this month for the Narcan use, and about 80 times this month we used Narcan. And so it seems like a lot of Narcan being used, and I think that really kind of breaking this down, thinking about it is important. So Narcan is great when someone's going into respiratory arrest due to an opiate overdose. Once the patient goes into cardiac arrest, then we have to start thinking about the things that make your life, the things that are going to improve outcomes and make your job simple. You want to focus on the things that are going to be critical actions. So critical actions definitely don't include Narcan in the cardiac arrest setting. So there's not any indication to give Narcan to reverse a person that's in cardiac arrest, whether it's any rhythm, VFib, PEA, asystole. So.
Okay, so what about the theory that we don't know what they've taken? Even then, it doesn't matter. It just should not be something that we're just throwing at patients, just blindly going, well, you know what, they're in cardiac arrest. Let's give them the whole drug box. Let's give them calcium. Let's give them Narcan. Let's give them, specifically Narcan. It's not going to help.
It's not going to help. Yeah. It's
okay.
Not going to help. And then to take it even a step further, not only that, but when the patient before they arrest in the peri-arrest period. The critical action, again, is not Narcan. The critical action is good ventilation. Ventilation is what's going to remove the CO2. That's going to actually lead them to start to wake up and minimize the amount of Narcan that you'll actually need to get the response that you're looking for. So again, like everything we talk about, there's the critical actions and then there's, we call style points sometimes. We use these terms. But yeah, so the main thing is the basic stuff. Good ventilation is the key for an opiate overdose, and then start to come in and give small doses of Narcan to slowly reduce the opiate overdose. That's something that's going to be beneficial for that early. You find the patient, they still have a pulse, they're in respiratory depression because of the opiate overdose, and you then.
Right.
Yes. Ventilation.
Yeah, that's a great point. I don't think a lot of people think about it, especially with the deployment of the Narcan with law enforcement prior to arrival. So we get there, they're like, oh, they gave 4 milligrams of Narcan, IN, and they're not waking up, and there's this like panic, and so we're like, oh, let's give another 2. That we might put them on a non-rebreather. You might do some BVM ventilations, but really we're pretty impatient type people. We want that instant satisfaction, that instant gratitude, that instant satisfaction. So it's like, well, let's give another 2. Let's give another 2. Why aren't they waking up? Right. So just focusing on those good BVM ventilations is just making sure that we take our time to give that half dose increment each time to make sure that they wake up.
Yeah.
Continuing the cardiac arrest discussion brings up a good topic that we keep talking about, Dr. Roach, and I know that this has been something we've been very passionate about, and unfortunately sometimes the EMS captains and myself have to bring you the unfortunate news to say that, listen, we go to these cardiac arrests and we're not seeing some of the stuff done that we're hoping to have done. And I know that's a training aspect that we're going to be rolling out as well. But what we're talking about today is epinephrine infusion. So, the epinephrine infusion, let's talk about why we started doing that.
Absolutely. So again, just to reiterate what we said before, we want to improve outcomes for the community, but at the same time making your jobs easier. So we did a deep dive into the medical literature, looking at epinephrine and its effect on ROSC and neurologically intact survival. And one of the key metrics is early epinephrine. Early epinephrine seems to have outcome benefit for ROSC in both the pediatric population and the adult population. So we wanted to get the epinephrine on as soon as possible. We recognize that scenes are chaotic and it's difficult. So our idea was, in order to make your jobs easier, that you would have an epi drip already made en route to the scene. When you arrived on scene, that would be one step you wouldn't have to think about. As Lieutenant Kravanek and I review the data, we noticed that there's many times where arrival to epinephrine is 8, 10, 12 minutes, which was not the ideal, which is not what we were looking for. So with that said, now we're starting to think, hey, you know what? Maybe in certain cases, if you arrive on scene and the epi drip isn't ready, let's give 1 milligram push of with the 1 in 10,000 and then flush the line while someone's hooking up the epi drip, and then we can start that. The other thing that happened too, as we learned as we went through this, is some of the medics actually told us that they weren't flushing the IO line, and therefore the drip wasn't running like it should.
I saw that several times. Like, man, the line's not running. I'm like, how many mLs saline bolus did you flush it with? Like, oh, we really didn't, or we did a 10 ml. The most optimal was like 10 to 20 mLs of fluid in order to get a good flush on that IO.
Yep. Yeah. So let's say you gave the 10 milliliter flush of the epinephrine, then you follow that with another 10 milliliters or 20 milliliters. Then you start your epi drip. I mean, it's the best of both worlds. But in ideal scenario, we would like to get the epinephrine on within 5 minutes of arrival. Within that first pit crew, which also speaks to another discussion maybe for another time, but the bundle of care is really what we're looking for in that first 6 minutes. As we've gone around to the stations talking about that first 6 minutes of the resuscitation bundle and kind of working your way through the pit crew diagram, that would be, I think, not only beneficial for the patients, but actually beneficial for you and your workflow.
So I was fortunate enough to be able to attend a couple conferences in the last month, EMS World and the EMS State meetings. And I got to tell you, man, being exposed to that kind of level of information is eye-opening. But when I bring that back to the department, specifically you, how we communicate that is via a protocol committee. And I don't know if everyone is aware that we have a protocol committee, but I want to make sure that everyone understands that how this stuff gets changed is by feedback from you guys.
Right. And this is your agency. This is your community. This is your metrics. Lieutenant Kravanek and I can sit here and we can talk all day long about what we want to accomplish, but if we don't have a group effort, if we don't have every member of this team on board with the same commitment, it's going to be difficult to be successful. Contrary, if we have everybody's buy-in, think of how successful we're going to be. Think of how proud you'll be as you see your metrics and you see these accomplishments that can occur. It's a deal breaker for your whole livelihood and the way you approach your job. So please come to the protocol meeting. Your voice is important to us. Be a part of the solutions for this agency. Drive what you think is important forward. We're here to listen. We're here to learn. We're here to grow and be the best we can be as a team. So you got to come. You got to show up to the meeting.
Yeah, we've gotten such great feedback from the last few meetings that we've had. The protocol committee members that are involved right now, just continuously showing up like they are, just really adds that level of pride that you can bring back to the field and say, look, this is, you know what, and we have a lot of new people, as you know, that we're hiring, and they may not understand these protocols and why we're doing these things, and they're the voices for the agency to come out of these meetings and explain, this is why we're doing it. We have the data. Dr. Roach showed me the data, and this is why we're doing it.
Yeah, absolutely. Lieutenant Kravanek leveled it up this last couple months with a new set of protocols, and I'm going to tell you, January, you'll see these new set of protocols for 2022. They are pretty awesome.
Yeah,
I mean, these things are going to be, they're going to be really, really awesome. Everything you can imagine is in these things now. I don't see anything leaving left out at this point. So we're about to take another step forward.
Yep, looking forward to it. We got a procedure section coming. Come to the protocol committee and get an eye get a view and a look and give us some feedback, we could use it.
Final message, everyone. I just want to say thank you for everything you do each and every day to help the community. And just also want to talk a little bit about the fact that that Delta surge that occurred in this Q3, July and August, this was definitely a painful time for everybody. And I'm certain that you went through a lot, and individually as well as professionally. So just know that I'm always here for you. If you need anything, please call me or text me. And if there's anything I can do to support you, it would be my honor to do so. Thank you.